Okay. So 9:03, 2 more minutes. Sai, light is clear?
Yes, sir. Fine, sir.
Okay. So we'll start now. I think there are more than 50 participants. Good evening, everyone. So we are just going to discuss regarding the HPV portion of INI CET super specialty of the last 2022 exams. Only regarding HPV. So I'm Dr. Santosh Anand. So for we have tried to get most of the questions, but some questions we didn't find the suitable options. We got only the questions, so we have put some dummy options. If someone remembers the exact options, please help us in coming forward and letting us know the options also. So for the next 1 hour, I'll be talking regarding this. Any doubts in between, you can post in the chat box. Okay. So the question is apple by procedure. So the options given were celiac artery resection. Second was celiac plus SMA. Third was celiac plus hepatic artery proper. And the fourth was celiac plus GDA resection. And the answer was celiac artery resection. So coming to its origin, where it originated. Please increase the screen size. And how do I do that? Someone has requested me to increase the screen size. So any suggestion? Someone is asking me to increase the screen size.
Sir, are you using
I can't see your PPT. Whether I'm sharing or not, they're not able to see my PPT, it seems.
No, it's coming, sir. The PPT.
I think the video is coming in big and slides in small.
Video will be come on little size, sir. And
comments are coming as slides are small and video is big. So tap on the slide, it will enlarge. I have tapped it twice. They are saying PPT is small. Sai, can you see to that? Or you can take my video up.
Now I have changed the slide, sir.
I'm just hiding my thumbnail video. Is it seen now? PPT, because I have my video, I have just minimized it to the minimum. So still same, sir. Okay, then I will stop sharing and share it again.
Yes, sir.
Okay, I'll stop sharing and share it again. Okay. I have double tapped multiple times. So how is it seen now? I think it's seen big only, no? Big only. Okay, fine. So what was apple by procedure? Apple by procedure So it originated particularly in proximal stomach malignancies, in which it was infiltrating into the left gastric artery either directly or through the lymph nodes and surrounded the celiac artery. But important thing is the origin of celiac artery from the aorta was not disturbed. So what they did total gastrectomy along with removal of celiac artery. They ligated common hepatic artery here so that blood to the liver went through the alternate SMA, pancreatoduodenal arcade, GDA, and into the hepatic artery proper. Since splenic artery was ligated, they did distal pancreatosplenectomy also for clearance sake and also for vascular purposes. Now, what we do in DPCAR is otherwise called as distal pancreatectomy and celiac artery resection. It is done for those tumors which are there on the So DPCAR is done for those tumors which are present in the body and infiltrating the splenic artery or splenic vein and the celiac artery proper, but without infiltrating the origin of celiac artery from the aorta. So in this case also similar thing is done, but they don't ligate or they don't do total gastrectomy. Instead, they ligate left gastric artery close to its origin so that it can receive blood through the alternate right gastric artery and from right gastroepiploic artery. So main thing is which we need to remember: superior mesenteric artery, pancreatoduodenal arcade, GDA should be patent. If that is not proper, this surgery cannot be done. So the next question is median uncinate first approach. It is useful in all of the following, or the advantage of medial uncinate process approach in Whipple's procedure is all of the following except. So the answer is we cannot identify replaced RHA, replaced right hepatic artery early. Instead, it will be identified late. So what are the advantages of medial uncinate process? First of all, what is medial uncinate process? So these are the 6 approaches described in that article by Dr. Sanjay Govil. So which is most commonly followed is the posterior approach or the right medial uncinate approach. So in this we go from caudocranial. The other less commonly followed approaches include left approach, mesenteric approach, anterior approach, and superior approach. But a combination of these two are the most commonly followed. Okay. So the advantages of medial uncinate approach is early identification of SMA at the uncinate. See, when we go here, we can definitely dissect the uncinate, particularly from the SMA. Early ligation of IPDA minimizes bleeding. Since we are handling somewhere here, the direct blood supply of SMA to the uncinate process through IPDA can be ligated so that when we transect, the bleeding will be very less. Useful approach in peripancreatic inflammation with difficult tunneling above portal vein for total pancreatectomy without transecting the gland. Yes, see, we are going to deal it here only. So whenever there is fibrosis expected here, instead of doing tunneling first, if we clear tissues here, then this becomes easy. But the disadvantage is, since the right hepatic artery replaced will go from here behind, when we are dealing here only after ligating IPDA and significant dissection of uncinate process, we will be able to reach this place where the replaced right hepatic artery takes off and goes above. So that is the disadvantage. Now the next question is, which drug is not used in the treatment of pancreatic neuroendocrine tumors? So the answer is straightforward. Sorafenib is used only in hepatocellular carcinoma and not in pancreatic neuroendocrine tumors. The other drugs are used in palliative care as palliative chemotherapy. It is not used as an adjuvant chemotherapy. Those include everolimus, sunitinib, and octreotide. See, octreotide, though they are proven and recommended to be used in functional neuroendocrine tumors, a few studies have also shown to increase the life expectancy or the progression-free survival in non-functioning neuroendocrine tumors also for very meager period, say 6 months or so. Okay. So there was another question in which the intra photo of Whipple's procedure was given after removal of the specimen, like the bed following pancreatoduodenectomy. So some structures were given labeling from A to D, all are true except we were not able to find the exact picture. So we given some dummy options. GDA is never removed in pancreatoduodenectomy. Obviously that is false because removal of GDA is part and parcel of Whipple's procedure. So the structure labeling is SMB, structure labeled B is the cut surface of the pancreas. So we just put a dummy picture. This is particularly Whipple's bed. So this is the region where the C loop of duodenum, head and neck of pancreas stays. So this is IVC, this is left renal vein. So this is aorta. From aorta, vessel which is originating and going anterior to the left renal vein is the SMA. Actually, SMV and portal vein comes here. It has been reflected using this instrument. Okay. So this is celiac artery which originates here, from which comes the common hepatic artery also. This is the liver bed and this is the transected surface of the bile duct. So what is Leach protocol? Leach protocol is related to one of the following, whether it's resection strategy or radiation protocol. Yes, SMV was retracted in that. SMV was retracted towards the left side. So Leach protocol options, dummy options include resection strategy, pathological assessment protocol, radiation protocol, and longitudinal division of the specimen is followed. So the answer is it's pathological specimen assessment protocol of pancreatic duodenectomy. So Dr. Joshua Richardson, SMV is usually to the right of SMA. It will be here, but we have rotated it or reflected it towards the left. So SMV is usually bigger than SMA. It is not anterior, it will be to the right, but we have extensively mobilized and reflected towards the left. Okay. So Leach protocol, usually we need to, after resection, this is the medial margin on the posterior margin, which needs to be painted. The orange is the SMA margin. See, for example, this is the uncinate process. After resection, it is painted like this. Okay. So orange is the SMA margin, blue is the SMV margin, and yellow is the pancreatic neck or the transection surface. So this is the complete posteromedial margin of the cut surface of the pancreas. So what is different in Leach protocol? In all other protocols, it will be divided like this. I think you are able to see my laser pointer. It will come from above downwards or the longitudinal division. Whereas in Leach protocol, they do transverse cuts and they check like this. So we will be able to see duodenum and the entire structure of the pancreas along with CBD and pancreatic duct as we come from above downwards, so that the medial margin where the SMV, SMA and the posterior margin can be clearly found out. So they did a study following pancreatic duodenectomy, strictly examining the specimens with Leach protocol. They were able to find nearly 40% of the specimens had R1 resection, which are within tumor within 2 millimeters of the transection surface. So another picture was given which showed triple phase CT of liver. 3 images were given. It actually showed enhancement in the middle image and washout in the last one. So we hoped it was first image was plain, second was arterial, and third was portal venous phase. So lesion, phase occupying lesion of the liver, which enhances in the arterial phase, washes off in the portal venous phase, is the hepatocellular carcinoma. So metastatic lesion of GIST will also have similar thing, but washout in the portal venous phase may not be very classical. Hemangioma shows peripheral puddling in arterial phase and centripetal progression in the portal venous and delayed phase. It will be progressive centripetal progression. Intrahepatic cholangiocarcinoma will be hypodense both in arterial phase and in the venous phase. It may have late enhancement, particularly in delayed phase, maybe 120 seconds later or 3 to 5 minutes later. So we put some dummy images. This is the plain image. This is the arterial phase, which shows an arterially enhancing SOL in the segment 7, which had washed off in the portal venous phase and seen as a buttonhole in the delayed venous phase. So this is HCC. So HCC is essentially a imaging diagnosis rather than a tissue diagnosis. So now we follow arterial phase and portal venous phase. No, one has to remember that whenever we say arterial phase, we are not going to do the early arterial phase. We are going to do the late arterial phase. So early arterial phase is 18 seconds. This is useful only to study major vessels like aorta till right and left hepatic artery. Beyond that, capillaries we may not be able to see. But when we do it in a late arterial phase, 35 to 40 seconds, the enhancement pattern of this tumor, which is occupying the entire right lobe, is clearly seen. whereas it is not very clear in the early arterial phase. So triple phase CT essentially includes late arterial phase, 35 to 40 seconds, portal venous phase, 65 to 70 seconds, and delayed phase, which is more than 120 seconds. Absolute contraindication for a living donor liver transplant for donation. BMI less than 20, no, it is good. Steatosis more than 5%, steatosis more than 60% is a contraindication. Age more than 50 is not a contraindication, but if the FLR of the donor is less than 30%, definitely it's a contraindication. So in donor evaluation, the acceptable donors include age 18 to 50 years, no comorbidities or one comorbidities such as well-controlled hypertension, liver attenuation index, which is the Hounsfield units of liver minus the Hounsfield units of spleen. In plain CT, whenever the fat of liver is less when compared to that of fat of spleen, the attenuation index of liver will be more when compared to that of spleen. I repeat, the attenuation index or the Hounsfield units of a normal liver is always greater than that of spleen. So when we minus the Hounsfield units of liver from that of spleen, it will be positive. That is called as liver attenuation index. When the fatty content of the liver increases, the attenuation index comes down. And beyond certain stage, this can become negative also when it is minus from spleen. So patient should not be obese, and graft recipient weight ratio should be greater than 0.8, and the remnant volume of the liver should be greater than 30% of the total liver volume. Okay. Now, relative contraindications include age greater than 50, LA between -5 to 5, slightly obese patients, GRWR or 0.8. Okay. The following tips. What is tips? Transjugular. So attenuation index, someone wants me to repeat. So these are the Hounsfield units of liver when compared to that of spleen. So whenever normal liver Hounsfield units are checked, attenuation is checked, it will be more than that of spleen. So when we subtract the spleen attenuation index from liver attenuation index, it will be usually positive. Now the liver attenuation comes down when the fatty content of the liver increases. Okay. So for example, if it was 47 in normal liver, when fat accumulation in liver increases, it can go down to 40, it can go down to 30s also. Now when this is subtracted from that of spleen, spleen will be constant usually. For example, it is 40. So 47 minus 40 is 7. Whereas if the liver attenuation comes down to 36, spleen is 40, then 36 minus 40 becomes -4. It is an indirect indicator of increased fat content of the liver. Okay, fine. I hope you understood Dr. Deertha Padia. Okay, the next question is following tips. Increased encephalopathy is seen in tips. Full form is transjugular intrahepatic photosystemic stent shunt. Okay, so it is a non-selective shunt. So whatever blood is coming through the superior mesenteric portal venous system is directly bypassed into the systemic circulation without being metabolized by the liver. Okay, so what we do, we cannulate the internal jugular vein, go to superior vena cava, go into the right atrium, cannulate the inferior vena cava, and from the IVC through one of those hepatic veins, we puncture into the liver and usually puncture again into the right portal vein. So the guide wire passes from the internal jugular vein, SVC, right atrium, IVC, hepatic vein, liver parenchyma into the right portal vein. Now we may need to introduce a stent because the liver parenchymal region, it may shrink. So stent usually has a covered end through the liver parenchyma and semi-covered end in the portal vein and in the hepatic vein. So whatever blood comes from the portal vein directly enters into the hepatic vein without getting metabolized in the liver. Okay. So when tips, then encephalopathy increases whenever the liver parenchyma is not functioning properly. So what happens in schistosomiasis? It is prehepatic block. AHPVO is also prehepatic block. VOD is veno-occlusive disorder. This is post-hepatic block. Liver will be functioning normally. But in NCPF, the microcirculation within the liver is not functioning properly. Okay. So extrahepatic, pre-hepatic includes extrahepatic and intrahepatic, hepatic and post-hepatic phase. So NCPF, cirrhosis, all these things, the hepatic encephalopathy risks are high. Whereas Pre-hepatic and post-hepatic, the risk is less. The patient of alcoholism came to emergency with hematemesis. What would be the immediate management? So all these are management of acute variceal bleed. So in this condition, alcoholic means we presume that patient is having alcoholic cirrhosis, following which he is having hematemesis. Nevertheless, the patient can also have bleeding from a duodenal ulcer or any peptic ulcer. In such situation, you cannot do any of the following, but octreotide, yes, you can start immediately wherever you are. This can be started in a primary health center also, secondary health center also. So what are the other options available? Somatostatin and so on. The Sengstaken and Bakemore tube is used. The role of propranolol is not there in setting of acute bleeding. Propranolol is used only for primary prevention or secondary prevention. Having said that, what is primary prevention? In patient with cirrhosis, we are doing annual surveillance endoscopy. If we find grade B or more cirrhosis, or the patient is decompensating, in order to prevent variceal bleed in an already established varices, we start propranolol. This is called as primary prophylaxis. What is secondary prophylaxis? Patient has already bled. Okay, number one. Number two, we have tackled that emergency situation. Now, patient, there is a chance of developing further varices. To prevent development of further varices, we give propranolol. So the role of propranolol is only in prophylaxis and not during immediate bleeding. Dr. Deetha, PPA can be given, but option is not there. Okay, PPA can definitely be given. So among the given options, IV octreotide is the most suitable option. Sengstaken and Bakemore tube should be inserted only in acute bleed, which doesn't stop with IV octreotide. We don't have an endoscopy in our setting also, so that we can insert the Sengstaken and Bakemore tube, fill the gastric balloon, pull it and hitch it on the GE junction, and then shift the patient to a place where endoscopy is available. Tips, yes, it is used in acute setting when endoscopy or endotherapy has failed. Endoscopic banding and endoscopic sclerotherapy are the definitive management most commonly followed for acute variceal bleed in most of the places. So next question is, all statements are true regarding the development of pancreas except. So the answer is ventral pancreas forms the body and tail and portion of head. It is actually the dorsal pancreas which forms the body, tail, and portion of head. The inferior portion of head and the unstable process is formed by the ventral pancreas. So Dr. Sir THOR, Thor, Surgeon Thor. So the role of SB tube, as I said, patient is continuing to bleed in spite of octreotide. You are in a peripheral setting, or specialist endoscopist has to come. Till then, in order to control bleed, we insert it, inflate the gastric balloon, pull it, hitch it against the GE junction also, and then shift him to a place where patient is able to get an endotherapy. Then that is the role of Sengstaken and Bakemore tube. Okay. So we'll go to the development of pancreas. So pancreas develops from both dorsal and ventral pancreatic bud, particularly at the junction of the foregut and the midgut tube. So this is the place where liver bud and the biliary bud also develops. The dorsal pancreatic bud is there, it doesn't rotate. It is there in a place where the future pancreas is there. It forms most of the head, neck, body, and tail of pancreas, whereas the ventral pancreatic duct, which forms the inferior surface of the head and uncinate process, as we can see, it is here, but slowly it rotates and forms the inferior portion and the uncinate process of the pancreas. Okay, so the ventral moves anti-clockwise. Fine. Regarding endocrine pancreas, all are false except. So the question is, which among the following is true? Ductal network is not essential for endocrine pancreas. It is necessary for exocrine pancreas. Majority of endocrine pancreas is contributed by beta cells, 55%. Beta cells receive mainly sympathetic supply. It is not parasympathetic supply. Though they constitute only 1 to 2%, they receive a massive blood supply of 20%, and that is a true option. So it is direct question from Bloomgart. See, the pancreas of healthy adult has approximately 1 million islet cells evenly distributed throughout the pancreas. This is not like beta glands move towards the tail. That is only in rodents. But in normal human beings, it is equally distributed in the pancreatic gland and forms only 1 to 2% of the organ mass, and each islet ranges between 50 to 300 micrometers. Okay, and the islet receives approximately 20% of the pancreatic arterial flow, with the distribution significantly influenced by different phases of digestion. Now, the second option, pancreatic alpha cells contribute 35%, whereas pancreatic beta cells contribute 55%. Delta cells, which secrete somatostatin, contribute the third commonest, 10%. Pancreatic F cells, which secretes PP for less than 5%, others are less than 1% only. So, contrary to what was previously understood, human beta cells are poorly innervated by parasympathetic cholinergic system. Instead, sympathetic system is also not direct. They innervate the blood vessels which supply the beta cells. So they indirectly control the beta cells. So sympathetic nerves indirectly influence the downstream endocrine cells by regulating the local blood flow containing the secreted endocrine hormone. So initially it was believed that parasympathetic innervation is more for beta cells. It is not so. Sympathetic innervation to the blood vessels which supply the beta cells are more. So they have indirect influence on the beta cells by controlling the amount of blood flow to the beta cells. Okay. So which statement is not correct with regards to xanthogranulomatous cholecystitis? It can coexist with malignancy. It never fistulizes with adjacent structures due to thickened wall. It forms fistula between stomach and gallbladder. It forms fistula between colon or duodenum also. See, now we should understand xanthogranulomatous cholecystitis, one of the form of chronic cholecystitis. So answer is, this I used to tell many times in my classes. Those who attend my previous classes will remember. Whenever there is an option which says never, usually that is the wrong option. And whenever something says like can present, could present, usually it will be true. Okay. So xanthogranulomatous cholecystitis, again, it's a direct question from Blogart. It's a subtype of chronic cholecystitis that can mimic gallbladder cancer. It can mimic. See, it can be associated with the gallbladder cancer also. For example, in a gallbladder, one portion can have xanthogranulomatous cholecystitis, other portion can have gallbladder cancer. But xanthogranulomatous cholecystitis per se is not a predisposing factor for gallbladder cancer. So the first question is, it can coexist with malignancy. They didn't say that this causes that. Okay. Second one, it is characterized by the destructive inflammation of the gallbladder wall, often accompanied by proliferative fibrosis, which means it will destroy the wall, and excessive histiocytes, acute and chronic inflammatory cells, all these will be seen. So there will be a thickening of gallbladder wall. Sometimes there can be mass formation which can fistulize into the adjacent organs also. Since it is a form of chronic cholecystitis, it can fistulize into the adjacent structures like stomach, colon, and duodenum also. So by doing cholecystectomy, common bile duct was injured. All are true except. So nearly all options were nearly correct, but this was fairly wrong option. So we will see the other options. Vascular injury needs to be assessed and addressed. Yes, definitely. Type of repair depends upon the size of the biliary duct involved. If it is very small, then better to do a hepaticojejunostomy. If it is big, then we can try off primary repair. Intrahepatic cholangiocarcinoma, definitely when anatomy is not clear and judgment is difficult, that can be done. Now, end-to-end repair, usually it is not preferred, but in case of an experienced surgeon, we can try if the injury is lateral, less than 1/3 of the circumference is involved. But the chances of stricture formation is definitely there. For vascular injuries, so that is the option. See, most of the injuries happen on the right side of the common bile duct. Now, on the right side of common bile duct, usually the right hepatic artery also goes. So whenever there is injury of the right hepatic artery, there is high chance that when we do an end-to-end anastomosis, since the blood supply is axial to the common bile duct, it goes on the 3 o'clock and 9 o'clock position. 3 o'clock position blood supply has been interrupted. So end-to-end anastomosis may end up with the stricture. So vascular injury, it's highly likely to be present, but when it is present, it is preferable to do a hepaticojejunostomy, because hepaticojejunostomy is also encouraged to be done at the level of hilum. Okay, there is something called as transhilar artery. See, there is right hepatic artery and left hepatic artery. So the 3 o'clock artery of CBD receives blood from the right hepatic artery. 9 o'clock artery I'm sorry, the 9 o'clock artery receives from the right hepatic artery, 3 o'clock artery receives from the left hepatic artery. And hilum will be receiving something called as transhilar artery, which can interchange whether right to left or left to right. Now, for example, if right side hepatic artery is injured, when we do anastomosis close to hilum, two blood supply is intact. One is the 3 o'clock position blood supply is intact, and the transhilar artery is also intact. And again, the jejunum which goes above also has its own blood supply. So 3 blood supply to a place where anastomosis happens, very less chance of stricture formation. But whenever the vascular injury has happened in acute setting, we may not know the extent of the vascular injury implication on the bile duct. So if we don't consider that and do end-to-end repair, there are chances of stricture formation. So a lady came to emergency. Vascular injury means injury to RHA or injury to usual vascular injury which accompanies with CBD injury is RHA. Okay. So moving to next question, a lady came to emergency with pain radiating to back, which was relieved after some time. So they were meaning a case of mild acute biliary pancreatitis. She has crossed 48 hours. Which of the following statement is true? I will interpret this question in another way. A patient with mild acute biliary pancreatitis which has settled with conservative management after 48 hours, which of the following is true? Patient needs to be discharged and asked to come for interval cholecystectomy. Early versus late cholecystectomy has no difference in outcome. Pre-op ERCP followed by cholecystectomy in this admission. Pre-op MRCP followed by cholecystectomy in this admission. So pre-op MRCP followed by cholecystectomy in the same admission is usually preferred. So what happens? Some sand or microliths from the gallbladder escape into the CBD while going through the ampulla. Due to some amount of inflammation or edema, it blocks the pancreatic duct transiently, thereby causing pancreatitis. Okay. Now, when it goes off, the edema comes down and pancreatitis is also relieved. This is what happens in the mild acute biliary pancreatitis. Okay. Now, in mild acute biliary pancreatitis, when patient is settling, it is prudent to do cholecystectomy in the same sitting. What happens when cholecystectomy is done in delayed sitting? So these are again a straightforward question from Bloomgard. It's a busy slide, but I'll just read for you. So this was one study in which 21% had unplanned readmissions waiting for more than 4 weeks for interval cholecystectomy. Okay. And even after doing ERCP and endoscopic sphincterotomy, 80 patients out of it, 60 patients had recurrent biliary complications, which means you have done ERCP in same sitting for prophylactically or for choledocholitis. But if you wait for 28 days, then there are chances of further admissions for biliary complications also. And recent multi-central RCT, it also showed that 129 patients were randomly assigned for early cholecystectomy and 137 for delayed. Readmissions for gallstone related complications were significantly more common in the interval group. So patient should not be discharged if it is mild acute biliary pancreatitis. Do an early cholecystectomy. Late cholecystectomy has more gallbladder related complications. Pre-op ERCP should not be done in all patients. If you have any doubt, do an MRCP. If you find any stone, then do ERCP. If you don't find any stone and LFT is an improving trend, only cholecystectomy will suffice. In carcinoma gallbladder, which is true, fundus, neck, and other parts of GB all have same survival and malignancy. No, fundus has got better prognosis. Neck has got poorer prognosis. Involvement of neck, resection with clear margin cannot be done. Papillary variety has got good prognosis. Carcinoma gallbladder in neck infiltrates into the hilum, behaves like hilar cholangiocarcinoma. See, the answer is obvious. It's the papillary variety which has got very good prognosis. Fundus has got better prognosis when compared to that of neck. Whenever neck is involved, the resection should be extensive. For example, it can involve the right hepatic artery, it can involve right portal vein. So in that situation, instead of removing segment 4B5, one may need to go in for right hepatectomy also in addition to 4B removal. Whenever it infiltrates the neck and cystic duct, it can infiltrate hilum also. Though it can mimic hilar cholangiocarcinoma, the prognosis wise, hilar cholangiocarcinoma has a better prognosis when compared to that of carcinoma gallbladder infiltrating the hilum. Neck cancer can present at early stage. No, it is actually the prevalence wise, the fundus carcinoma is more, and that has got a better prognosis. It has been studied epidemiologically. Okay. Neck cannot present early. Why it should present early? Only when it has progressed and has involved the hilum, it can cause jaundice, and then it can present. Okay. By the time it has progressed and involved hilum, it is already advanced. It is not early. So, which is correct statement regarding laparoscopic cholecystectomy? Rubeus sulcus overlays segment 4B and is adjacent to common bile duct. No. What is Rubeus sulcus? It is the external impression of where the right posterior artery, duct, and vein goes in. Cystic duct should be clipped first. Preferably, cystic artery is clipped first, because if we clip the cystic duct and divide, cystic artery can sometimes slip. The other reason why cystic artery should be clipped first is after clipping cystic artery, we will get a bit of extra length of cystic duct for it to clip and cut in between. Visualization of Rubeus sulcus via calyx triangle is critical view of safety. No. Visualization of the liver bed through the triangle of safety is called as critical view of safety. And critical view of safety should be checked both anteriorly and posteriorly. Yes, it is true. So this is critical view of safety, and this is the Rubeus sulcus. Usually we don't see Rubeus sulcus through the critical view of safety. So there are so many things, elephant sign, Ganesha sign, and so on. Okay, both anteriorly and posteriorly it has to be checked. This is anterior, and posterior reflect to the left side and check from the other side. Okay. Most common anomaly of gallbladder is the low insertion of the cystic duct. It can occur as high as 20%. Okay. The other anomalies of agenesis of gallbladder is extremely rare, double gallbladder is extremely rare, left-sided gallbladder, all these can occur less than 2%. So again, a direct question from Bloomberg. Which of the following is false regarding hemophilia? The classical triad of pain, jaundice, and GI bleed is seen in 22% of the case. Anyone, what is this triad called as? CT angio is most appropriate investigation of choice. True. Most commonly due to penetrating injury than blunt injury. Yes, it is called as Quincke's triad. Percutaneous procedure hemophilia is observed up to 1%. So all options are true except it occurs following blunt injury more common than the penetrating injury. Okay, so it is called as Quincke's triad. Glisson actually guessed the possibility of hemophilia, but the hemophilia term was coined by Sandbaum. Okay, so no confusion. Glisson guessed the possibility, Sandbaum coined the term, and it is called as Quincke's triad. It can occur in 16 to 25% of the patients. So a short discussion about hemophilia. It's most common following trauma, which can be most commonly blunt trauma following by penetrating trauma. And after the innovation of percutaneous procedures, iatrogenic reasons have come up. Arteriography, CT angiography is the best. When you find by CT angiography, angiographic embolization is the treatment of choice. So trauma is the most common cause. Hemophilia following PTBD, the tube repositioning or upsizing is generally all that is required to tamponate the bleeding site. So what happens whenever we insert PTBD tube, it could have gone through small arteries and then entered into the bile duct. So there will be many side holes in this tube. So one of the side holes, when it is present within the artery, so blood goes through that and comes out through the another side hole which is present within the bile duct. So how to prevent it? Either push it inside nicely or you upsize it. While upsizing it, what happens? The tract becomes or gets a tamponade effect. Okay. So again, percutaneous cholangiographic hemophilia is usually minor. Okay. So whenever percutaneous things happen, it is usually minor. It is not significant enough, requiring angioembolization. The management of portal venous bleeding following PTBD, which should be first catheter repositioning, as I said. Okay. Surest sign of declaring brain death is no response in respiration despite increasing PaCO2 more than 60. So all these, like no motor response, no verbal response, no eye movements, all these can occur and they are essential criteria for declaring brain death. But all those are, it is subjective. It can vary from assessment from one patient, one doctor to another doctor. As Dr. Serge Thor said, no response in respiration despite increasing PaCO2 for more than 60. It is called as apnea breath test. And two different settings. Apnea breath test at two different settings is the surest sign of declaring blood death. So a patient should be in coma and all brain stem reflexes should be gone. This brain stem reflexes include pupillary response to light, absence of corneal caloric response, gag reflex. This is coughing in response to tracheal suctioning. And this is the apnea breath test, which is absence of respiratory drive at a CO2, very high CO2 of 60 millimeters of mercury or 20 millimeters above the baseline value. And all these should be documented with two evaluations at least 6 hours apart. Okay. The next question is, the middle-aged male patient with regular complaints of pain, abdomen radiating to back, essentially pancreatitis, underwent following surgery. A CT shows calcification of pancreas and an intraop photo showing Fraser procedure, means a chronic pancreatitis patient following Fraser procedure. All of the following are true except the procedure done above is Fraser procedure. Celiac plexus block gives better pain relief than surgery. No. Biggest procedure involves resection of head, yes, along with transection of the neck. Fraser procedure involves coring of the head with laying open of duct in the body and tail. So definitely surgery gives better pain relief when compared to that of celiac access block. So this is what is done in Fraser procedure. Head is cored and the duct on the body and tail is laid open. Single anastomosis of jejunum. So this is Biggest procedure. In this, we can see the amount of head cord is more and the neck is transected. We don't lay open the duct. Instead, we do anastomosis, two different anastomosis. One is to the cord head, another is to the duct. In order to minimize the morbidity and the difficulty of the procedure, see, chronic pancreatitis, there will be significant peripancreatic inflammation or fibrosis, and the development of the tunnel in the region of neck above portal vein is very difficult. So in order to simplify this, head was cored and the scoring was extended onto the neck. So that duct opening is also seen. So this was anastomosed to the single loop. This is called as Burns procedure. Okay, the simplified form of Biggest procedure is the Burns procedure. So indications of surgery in chronic pancreatitis: intractable pain, symptomatic local complications like pseudocyst, unsuccessful endoscopic management, and suspicion of malignancy. Whenever there is suspicion of malignancy, you should do resectional procedures. So resectional procedures include pancreaticoduodenectomy, and when there is mass in body and tail, you can do distal pancreatectomy. But pancreaticoduodenectomy is an extensive procedure for benign condition like chronic calcific pancreatitis. They also, following classical pancreaticoduodenectomy, significant amount of intestine is also lost. So nutritional deficiency is also used to occur. So in order to decrease that, significant portion of head was cored and the intestine was kept intact. And what are the different forms of coring head? Include Biggest procedure, Burns procedure, and Fraser procedure. Okay. So Dr. Divya Jha, how can we assess whether the head coring is adequate? Usually, extensive cauterization is done. One hand is placed behind. Initially, it was said that when you see the posterior capsule of pancreas, that is enough. But these days, a slight amount of tissue should be present above the level of CBD, and that is considered as adequate. Accidentally, if CBD is opened, we can do double anastomosis, but it is better to avoid opening the CBD. So just above the level of CBD is what is enough. All statements are true for polycystic liver disease except it is mostly accompanied by polycystic kidney disease. Yes, though it equally occurs in equally common in males and females. Around 85% of symptomatic acelia in males, it is false. And that is the answer. 6 months therapy with octreotide has shown a decrease in liver size in PCLD. It may seem to be wrong. Incidence and numbers increases with age. Yes, it is true. So between B and C, whenever we have such confusion, we just go back and check. Bloomgart is a direct question from Bloomgart again. The overall prevalence is same in men and women. But for simple cyst, women have more severe liver disease than men. And multiparity as well as use of oral contraceptive drugs also tend to worsen the condition. So, though it is common in male and female, symptomatic PCLD is seen in women. Now, regarding this option, whether it is correct or wrong, 2 randomized control trial demonstrated 6 to 12 months of treatment with lanreotide, which is a long-acting octreotide, significantly reduced the liver volume in patients with PCLD. Now, the question will be, then why cannot we start using octreotide? See, however, this decrease in volume is limited only for 3 to 5% of the liver volume. Severity of abdominal symptoms did not improve significantly. And after 6 to 12 months, there was no further reduction, and once the treatment was stopped, liver volume rebounds to the baseline. So the blunt answer is yes, it reduces, but only marginally, and after stopping it, it comes back to the normal size. So the seemingly wrong answer was actually correct when we go back to Bloomgart. Which drug is not given in celiac block? Celiac plexus neurolysis is done in unresectable CA head of pancreas. It is also done in chronic pancreatitis also. So we use either local anesthetic agent, which gives temporarily relief, maybe for weeks to 1 month, or we use absolute alcohol or phenol to give prolonged relief, maybe for 6 months to 12 months. The triamcinolone alone as a steroid is not used in any nerve blocks. Okay, that is used only in keloid conditions or to improve the mobility in osteoarthritis. So moving on to pyogenic liver abscess, all of the following are true except Klebsiella causes metastatic pyogenic liver abscess. Yes, it is true. Pyogenic liver abscess of biliary origin has got worse prognosis. Is either it is iatrogenic or it happens in patient with malignancies. That's why the prognosis of baseline disease itself is poor. And when baseline disease is poor, superadded pyogenic liver abscess definitely has a worse prognosis. Both pyogenic liver abscess and amoebic liver abscess have same prognosis. No, pyogenic liver abscess has got a worse prognosis when compared to that of amoebic liver abscess, because amoebic liver abscess is slow, indolent, occurs in young patients, whereas pyogenic liver abscess occur predominantly in older patients with underlying diseases, diabetes, malignancies, and so on. Gas-forming pyogenic liver abscess are caused by E. coli. So the answer is PLA and ALA has got same prognosis. No, they have different prognosis. So coming on to the short discussion regarding the pyogenic liver abscess, the most common feature is polymicrobial. Most common anaerobe causing is bacteriotype. If it is hematogenous spread, see, pyogenic liver abscess can occur through blood spread. It can be from portal vein, it can be from hepatic artery, it can be from bile duct, or it can directly spread from adjacent organs like colon. So most common hematogenous spread through arteries due to streptococcus or staphylococcus. Most common in children is caused by staphylococcus, particularly in chronic granulomatous disorder patients in whom the immunity is less. In West, it is caused by E. coli. In East, it is caused by Klebsiella. So hematologic malignancies and chronic granulomatous diseases, staphylococcus causes. Then associated comorbidities like cirrhosis, CRF worsens the prognosis. Solitary abscesses are more likely to be polymicrobial. Multiple abscesses occur in patients with biliary origin. Yes. So right lobe is most commonly involved because of the streaming effect of the SMB. Earlier, the underlying cause was appendicitis, but these days, 35 to 45% of biliary malignancies are used. Underlying disease or an immunocompromised host, most important prognostically than solitary versus multiple abscess. So ALP level is mildly elevated in 80% of the patients, which is the most common biochemical change in the alkaline phosphatase levels. Bilirubin change is the least common, and transaminases level elevation is seen in 60%. So 80% ALP, 60% transaminases, only 20% bilirubin. So diagnosis with USG and CECT double target sign, and high success rates with PCD and low mortality. Correction of the underlying cause as well has to be seen. Okay. So some questions: what is the difference between celiac plexus block versus splanchnic plexus? See, splanchnic block is at a higher level, at T11, T12 level, but celiac plexus block is at the level of the celiac artery. So these days, particularly in pancreatic malignancies, since the innervation comes from slightly above level, splanchnic block is preferred when compared to that of celiac plexus block. And yes, I have seen patients who have better symptomatic relief with splanchnic block when compared to that of celiac plexus block. Dr. Virendra Kumar sir, in Bloomgart answer given as bupivacaine, triamcinolone is also there. I have to check, to be very honest. But I hope triamcinolone is a steroid particularly used in other places. I check and get back, sir. Get back to it. So daily biliary output is around. See, these were the options given: 900 to 1200 ml, less than 500 ml, 500 to 800 ml, more than 1500 ml. Any answers? So this was the direct line taken from Dunga. So you can decide. So 700 to 1000 ml. So 900 to 1200 ml was the closest I was able to find. Okay. A patient of external biliary fistula, tube accidentally removed after 14 days. What should be done next? Operate immediately. No need to reinsert. Do ERCP or reinsert the tube. See, by 14 days the tract would have formed. So better to reinsert the tube. Which is not done in pancreas transplant. SMA is anastomosed to external iliac artery. Duodenum is sutured to the bladder. New pancreas is kept in original place after removing the old pancreas. Portal versus systemic drainage is debatable. So the answer is, just like kidney, we are not going to remove the orthotopic pancreas. Only in liver, we remove the native liver and then keep that in the orthotopic position itself. Whereas kidney and pancreas, it is in the heterotopic position only. So SMA is usually anastomosed with external iliac artery, and SMV is anastomosed with the top external iliac vein, or it can be anastomosed into IVC also. So the drainage can be done either into the bladder or it can be done into the small intestine. Now, the question is, it can be anastomosed with the portal vein also. In case of portal vein anastomosis of SMV, definitely the physiology is much better when compared to that of drainage of insulin into the systemic circulation. So, but the ultimate effect of the pancreas transplant, whether the anastomosis is done with the external iliac vein or the portal vein, it is not going to change. So a patient having ascites underwent TIPS. Which condition has the best outcome? Any answers? So the child A patient has only a better outcome and compared to that of child B and child C, because child B and child C patients will end up in acute liver failure or hepatic encephalopathy. Okay. So statements regarding management of carcinoma gallbladder were given. So we were not able to find the correct option. So we gave some dummy options. Celiac node involvement is considered as distant metastasis. Yes, para-aortic node involvement is considered distant ones. Jaundice is equivalent to inoperability. No. Inoperability is decided based upon the distant involvement or the nodular involvement. Retropancreatic node involvement comes under unresectable criteria. No, it comes under the resectable criteria only. Routine 16B1 sampling needs to be done in patients preoperatively diagnosed with CAGBC. CAGB we can suspect with imaging findings. Okay, excuse me. So CAGB can be found in imaging findings when we suspect. Definitely, we need to do a staging laparoscopy and then do extensive cauterization. Sample some nodes from the 16B1. 16B1 is a para-aortic infrarenal node. So that has to be sent for frozen section. If that turns to be negative, only then radical cholecystectomy has to be done. So a small idea about how the CAGB spreads, it first spreads to the cystic nodes, then into the CBD nodes, and then into the retropancreatic nodes, then into the para-aortic nodes. So there are three pathways. Cholecysto-retroduodenal pathway, cholecysto-SMA pathway, and cholecysto-celiac pathways. So all these nodes should be removed before entering into the intra-aortic lymph nodes. So essentially, what are the lymph node station cleared? Retropancreatic nodes, hilar or HDL group of lymph nodes, left gastric artery lymph nodes, and remove a portion of segment 4B and 5. So this is the intro picture of the schematic representation given in the previous slide. Okay. So CAGB with jaundice, it can be resectable, it can be unresectable also. Okay. So this is taken from the management portion. It can be resectable. If it is resectable, consider neoadjuvant therapy, but with jaundice, it is very difficult to give neoadjuvant therapy. You can directly go in for en bloc resection along with lymphadenectomy, then give chemotherapy. If it is unresectable, then do certain molecular testing and give systemic therapies. Okay. So we didn't find any options for alcoholic steatosis versus NaH. All are true, except if someone remembers, please help us in finding the options. So I just try to scrutinize the NAFLT grading. It is by Cleaner and colleagues. It is typically graded according to the scoring system. 3 factors are taken into consideration. First one is degree of steatosis, 0 to 3. See, this is pathological staging. You take a liver biopsy and subject that for microscopic examination. Take 3 factors into consideration. Degree of steatosis, 0 to 3 points are given. 0 being least steatosis, 3 being the maximum steatosis. Lobular inflammation, again 0 to 3 points. And hepatocellular ballooning, 0 to 2 points. So when we add, the least point is 0 and the maximum point is 7. Any score of 5 or more indicates steatohepatitis. So NAFLD is termed as steatohepatitis if the cleaner score is more than 5. Okay, so that we will take. Thank you, Dr. Deertha. Malary then bodies are seen in alcoholic, whereas it is not seen in NASH. Biopsy findings were given between them. Malary dent. Okay, thank you. You'll just note that. So patient underwent Linton. Again, this we didn't find any options. Showed increased encephalopathy. So someone remembers, please do help us. We thought we will just discuss about the most common shunts which are being done. So this is side-to-side portocaval shunt. This is end-to-side portocaval shunt, or the egg fistula, which is no more being followed. So this is the most commonly done shunt, which is otherwise called as proximal renal shunt. What we do here is we do splenectomy along with the proximal splenic vein, which is anastomosed with the side of the renal vein, left renal vein. So this again is a non-selective shunt. So this is Warren shunt, in which the splenic vein is ligated, spleen is kept intact, and the distal splenic vein is anastomosed to the side of the renal vein. Now, why it is called as selective and non-selective shunts? See, non-selective shunt means whatever blood coming from the portal system is directed into the systemic system through the IVC directly or through the left renal vein. In selective shunts, what is done is only those blood vessels which will supply the stomach or gastroesophageal junction. For example, through the left gastric, gastroepiploic and short gastric veins, the spleen will be supplying the stomach, most of the portion of the stomach and the GE junction. So if we divert that amount of blood only into the systemic circulation, then blood coming from the SMV will enter into the liver. So it is a selective shunt. Okay. The other shunt is called a Charvet shunt, in which side-to-side portocaval shunt is done using an 8 mm graft. Why the size is 8 mm? It is believed that it is partial shunt. Whenever the size of the graft used is more, then more amount of portal vein will enter into the IVC. Again, it becomes a non-selective shunt. But if the size is restricted to 8 mm only, then only a portion of portal vein will enter. This is enough to decompress those varices, whereas blood may enter into the liver for it to undergo metabolism. Okay. So repeat the first portion: selective and non-selective shunt. Non-selective shunt, all the blood from SMV enters into the systemic circulation, whereas in selective shunt, those blood vessels which drain most of the stomach and gastroesophageal junction is diverted into the systemic circulation, which is the distal spleen or renal shunt. But the disadvantage is they will develop collaterals and this will become non-functional over a period of time. So those were the questions which were of HPV portion. So I think I have covered them. Just see page number 929. So any questions ready to answer you? There's one new message. vascular injury during cholecystectomy. See what happens. The right hepatic artery goes close to the portal vein. I'm sorry. Right hepatic artery goes close to the common bile duct. And whenever the injury happens, the right hepatic artery is also injured. So axial blood supply, like CBD receives blood supply through two blood vessels which are going very close to or the axial blood vessels along the CBD. So the 9 o'clock position blood supply will come from right hepatic artery, 3 o'clock will come from left hepatic artery. Whenever we try to do an end-to-end anastomosis, the 3 o'clock blood supply, 9 o'clock blood supply, the right side blood supply may come down because the vascular injury would have happened, and that may result in stricture. Whereas if we do an hepaticojejunostomy at the level of hilum, there will be intact left hepatic artery or the left-sided blood supply, and transhilar blood supply also intact, along with jejunum, which has got its own blood supply. Okay. Bariatric surgery in cirrhosis patients. Bariatric surgery in cirrhosis patients are preferred surgery is sleeve only, and we don't do bypass. Okay. Critical view of safety. One option was segment is seen between window GB is retracted laterally. What we see is segment 5 on lateral side. When it is reflected medial side, what we see is segment 4B. So there is another new message. Virendra Kumar. We will changes. We will come again with another Zoom session. Okay, so that we are yet to do it and come back to you. Like we once did for Sebastian last time. This time we will do for Bloomberg also. But please do bear with us before that. Expected important topics. It is like all aims. See, aims, it is preferably taken from Bloomberg only. Sebastian update classes, I think it was already done. We'll discuss with the team and get back for this. So, Appleby procedure, it is done initially for proximal gastric cancer, where left gastric and celiac artery was involved. Most important thing is the junction of celiac and aorta should be free. So, in there, what they did total gastrectomy, and they ligated common hepatic artery in its origin, believing that the SMA, pancreatic arcade, and the GDA is intact, so that this can supply the liver. Okay. In modified Appleby procedure, stomach is kept intact, but we do distal pancreatectomy and celiac artery resection alone. In this, the left gastric artery is ligated close to its origin, so that the arcade where it's joining with that of right gastric artery is not damaged, so that right gastric artery can enter into the arcade, supply the left gastric artery and that region also. Okay, so I hope I answered the Appleby and modified Appleby procedure. 7th edition updates, we will come with another session, definitely. Dr. Virendra Kumar, can you tell me in which chapter the triamcin alone had come? Dr. Virendra Kumar Deshmukh, so that I can correct myself. Chapter 58. Okay. Okay. So actually, I have an e-copy. PDF sharing, yes, we will get that in the Telegram. Okay. Till now, only hard copy. That's what. Once we get it, we will share with you. So, if there are no more questions, I think we can call for today. I think I just crossed an hour. I hope I maintained my time. Okay. Thank you, Dr. Virendra Kumar. I'm actually finding agents most commonly used for this purpose include alcohol or phenol for neurolysis and bupivacaine and triamcinolone for temporary block. So the answer there should have been lignocaine. So those who are present, I'll just go back to the slide and I will correct myself. In celiac plexus block, which drug is not given as lignocaine? Bupivacaine, phenol, and triamcinolone is preferred. So sorry for that, and thank you very much, Dr. Virendra Kumar Deshmukh. I just saw from other pages. Thanks for that. So if we had left any questions from the INI CET HPV portion of 2022, please get back to us in our WhatsApp group. That will help us a lot. Okay. So anyone interested in learning laparoscopic procedures, this is my YouTube channel where I have described step by step of lap hepatectomies, lap right posterior sectionectomy, lap pimples, thoracoscopic esophageectomies, lap radical cholecystectomy. So thanks for that, and I'll call for the day. Thank you. See you all.